Okay, we're going to finish up our discussions of alcohol by talking about alcoholism and alcohol abuse. In particular, we're going to talk about some of the consequences of alcohol abuse and talk a little bit about potential treatments for alcohol abuse. Let's start with talking about the consequences of alcohol abuse. In particular, we're talking about chronic excessive alcohol use. It should come as no surprise that one of the serious consequences of alcohol use was found by a Russian. Russian folks are well known for their heavy drinking of vodka. I'm Irish myself, and my people are certainly known for our ability to put a few away, so it's not a criticism. Sergei Korsakov, who's pictured here, discovered that there is a specific syndrome associated with chronic alcohol abuse. It's primarily due to damage to the frontal lobe tissues and to the hippocampus. This is a permanent amnesia in which no new memories or learning can take place. And so this is what we call an anterograde amnesia. It's an inability to form new memories. People with this syndrome have normal IQ. There is some confabulation. It's possible that these folks will improve or even recover with thiamine replacement. What happens is chronic alcohol abuse shuts down the liver's ability to process thiamine. And so what we now know is that loss of vitamin B12 is associated with damage to the hippocampus, in particular the pyramidal cells of the hippocampus. And so an important part of managing the effects of alcohol abuse is to assure appropriate nutrition. And so one thing you can do is take a good vitamin. Vitamin B will actually help you recover from a hangover relatively much easier than if you don't include a vitamin. Fetal alcohol syndrome is certainly an important consequence of alcohol abuse. Pregnant women should be very cautious in their use of alcohol. This occurs in the offspring of mothers with high blood alcohol content during critical stages of fetal development. Occurs in about 3 to 5 out of 1,000 live births, in 30 to 50% of alcoholic mothers, and we have about 2.5 million infants who are born in the U.S. annually with fetal alcohol syndrome. The features of this include central nervous system dysfunctions, which includes mental retardation, reduced brain size, behavioral abnormalities, which are similar to attention deficit hyperactivity disorder. There is a retarded body growth rate, and very clear identifiable facial abnormalities we'll look about here in a moment. There are also possible congenital heart defects. So at some level, alcohol is a teratogen, certainly associated with a variety of problems in children born to alcohol abuse. So if we look at the brain of a normal baby versus a fetal alcohol syndrome baby, huge difference there. This is a child with fetal alcohol syndrome here. One of the things you'll notice is some very clear flat mid-face features, short nose, thin upper lip, some ear abnormalities. You get these very odd-shaped eyes. All are associated with fetal alcohol syndrome. This, of course, can lead to alcoholism, which is a primary chronic disease with genetic, psychosocial, and environmental factors influencing its development and manifestation. The disease is often progressive and fatal. It is characterized by impaired control over drinking, preoccupation with drug alcohol use of alcohol despite adverse consequences, distortions in thinking, and most notably denial. So alcoholism is different from just somebody who likes to drink alcohol and just doesn't have a handle on it. This is a disease. And again, there are genetic, psychosocial, and environmental factors that influence its development. So understanding alcoholism is, of course, important. We need to really think about how alcoholism evolved as a disease model. In 1935, we get the founding of Alcoholics Anonymous, which was founded on a moral model. There's a lot of criticism of AA. I think it's probably done a lot of people good, but it certainly has its issues. AA offered a spiritual and behavioral framework for understanding, accepting, and recovering from alcoholism. As a neuroscientist, I think it's important we understand there is a biological basis to this, but if recovery to that biological phenomenon is through this program for some people, then that's acceptable. I think anything that helps people is important. I think it's a good tool for those it works for. So definitely supportive there. We do now know it's really more of a disease concept. This happened in the 1940s. Defined alcoholism as any use of beverage alcohol that causes damage to the individual, drinker, to society, or both. From a psychological perspective, we often talk about alcohol abuse as a diagnosis if it interferes with the occupational or social functioning of the individual, so somebody who's clearly disordered, and I think that's important to understand. In 1957, we get the AMA defining alcoholism as a disease, and then in the 70s as a chronic, progressive, and potentially fatal disease. The description has been expanded to include genetic, psychosocial, and environmental factors. We know that there is behavior behind drinking. It is a learned but maladaptive behavior, which is the behavioral model. We have, of course, the self-medication model, where drinking is a means of self-medication for psychological distress. There is certainly evidence for that in the high levels of alcoholism in individuals with post-traumatic stress disorder. This is an issue which has resurfaced. This first came important after the Vietnam War, and certainly we now know those returning from the War on Terror have a great deal of problem with this as well. There is a genetic contribution. This disorder occurs in all classes of society and walks of life. But you can breed animals that respond differentially to alcohol, so it's something that might be inherited. There's certainly clear components to the taste of alcohol, to the preference for alcohol, to the potential for abuse of alcohol. We think this is true for all drug abuse. We know alcoholism runs in families. Children of alcoholics have a much greater risk, particularly men. The normal prevalence of alcoholism is about 3 to 5% versus 20 to 50% in male offspring of alcoholics, whereas with females it's about 0.1% in the general population versus 3 to 8% in offspring. There is a great deal of comorbidity associated with alcoholism. Much alcoholism might be associated with other psychopathology. About 30 to 50% of alcoholics meet the criteria for major depression. So again, there is this idea where people are using alcohol to medicate themselves, to just escape from their life's troubles. About 33% of alcoholics have a coexisting anxiety disorder, so the alcohol might treat that anxiety. 38% have an impulse control problem, so they just can't inhibit the impulse to drink alcohol. And again, we have to think about whether or not there's a dual diagnosis, and we usually presume that there is until proven otherwise. There's almost always an underlying factor that is associated with the alcohol abuse. And this is true of a lot of these compulsive disorders. If you watch Intervention or you ever watch Hoarders, there's almost always an underlying issue that has led to this problem. Now, it might have led to the problem 20 years ago, and now the problem is treating the alcoholism. So you have to think about whether or not there might be something else involved. It doesn't have to be, but there often is. Okay. So how do we treat alcoholism? Well, the ideal goals of any pharmacotherapy, certainly for alcohol abuse and dependence, should be reversal of acute pharmacological effects of alcohol. We want to keep people from having seizures or having the DTs. We want to treat and prevent withdrawal symptoms and complications. We want to maintain abstinence and prevent relapse. And we, of course, want to treat coexisting psychiatric disorders. And then finally, we want to have a limitation of neuronal injury during detoxification by blocking the withdrawal-induced glutamatergic activation and glutamate receptor upregulation. One of the things that alcohol does is it has an effect on the glutamate system. We didn't talk much about the specific neurotransmitters involved because it's not clear, but there's certainly a glutamate regulation problem, and so one of the things we'll want to do is treat that with some drugs. So, as yet, no agent can reverse the acute pharmacological effects of alcohol. There are, however, pharmacotherapies available for the following: to treat and prevent withdrawal symptoms, to reduce relapse to drinking behaviors, to treat complications in alcohol-dependent people who are decreasing or discontinuing their alcohol use, and to reduce that glutamate release and glutamate receptor upregulation so we can reduce that subsequent neuronal damage. So, what treatments do we use for alcohol withdrawal? Well, benzodiazepines, which will of course increase GABA activity, which will inhibit neurotransmitter activity or inhibit neural firing. This ameliorates withdrawal symptoms, will prevent seizures and the DTs. By using long-acting benzodiazepines, we can prevent withdrawal symptoms, either maintained or slowly withdrawn, allowing the person to function through the withdrawal period. The drawbacks are, of course, people can be sedated, there are psychomotor deficits, there are additive interactions with alcohol, and of course there are abuse and dependence liabilities, where what we might end up doing is replacing alcohol with Valium. So we want to be very careful with that. Anticonvulsant mood stabilizers can also manage withdrawal. There are fewer limitations than benzos. The older anticonvulsants are effective, but of course have their own side effects, including liver and pancreatic problems, which could be, of course, compounded in somebody who already has liver and pancreatic problems. These will include Tegretol and Tepakote. Newer anticonvulsants are less toxic and have significant potential. These are things like gabapentin or oxcarbazepine. Now, there are also drugs to help maintain abstinence and prevent relapse, which include alcohol sensitizing drugs, which include a drug called Antabuse, which produces adverse reactions if the patient drinks, makes people very sick. There are also opioid antagonists, like naltrexone, which inhibits the reinforcing properties of alcohol. So blocking opioid receptors can block that craving associated with alcohol. Problem is treatment compliance. Our last pharmacotherapy treatment to try to, no, it's not the last, sorry. One of the next major drugs is to help maintain abstinence and prevent relapse is Camprol. Is the first pharmacological agent designed to maintain abstinence in alcoholics after their detoxification. It's both a GABA agonist and an NMDA inhibits neural firing by being a GABA agonist and also inhibiting the NMDA receptor, similar to the effects of alcohol. It's comparably effective to naltrexone. A combination of both drugs might be additively effective. Finally, we can also use Wellbutrin, which has a theoretical use. Both positive reward and withdrawal seem to involve the dopaminergic reward system, so that might help. Other areas of interest for investigation include serotonergic drugs, nicotinic mechanisms, and cannabinoid mechanisms. So there are pharmacological treatments. There are, of course, behavioral treatments as well, and oftentimes the two will work in conjunction with one another. Thank you.